So thanks for coming out. I'm Dr. Martindale. I'm an associate professor of breast imaging at MD Anderson, and I work primarily out in the Woodlands location. So we're going to talk a little bit about breast cancer, risk reduction, and then I also had a request to bring some statistics for Hispanic Heritage Month. So we've got just some incidence numbers and things that we'll go over at the end that specifically apply to that part of the population. And then we'll go over any questions that people might have, especially if there's things that aren't a part of the presentation that y'all have questions about. So first thing, talking about how we get from having a cancer cell to what you would call a tumor. So cancer is not one single disease. It's a large group of diseases that depends on where the cells that form that cancer arise. So they're going to be treated differently. They're going to have different degrees of, how aggressive they are, whether they spread, that sort of thing. Now, if you have a type of cancer that's, or a type of tumor that's benign, because you can have benign tumors, meaning not cancer, those can still grow in an uncontrolled way, but they don't spread to other parts of the body and they're not going to be deadly. So cancers or tumors that are cancerous or malignant also do that same sort of uncontrolled growth, but there's the potential for them to spread to other parts of the body and potential for them to be lethal. And those are the kinds of tumors that we're talking about today, those cancer cells. Now, the anatomy of the breast is a combination of fats and fibroglandular breast tissue. So within the breast, you have these lobes. The normal breast has got 15 to 20 different lobes. Each lobe is made up of several lobules, and that's where the cells that produce milk live. And then the ducts that connect those lobules drain towards the nipple. And then there are also lymph nodes that everyone has throughout their body, but the lymph node drainage for the breast is mostly lymph nodes under the arm, though you do have some that live up around the clavicle or the collarbone and then in between the ribs as well. And this is the same for men and women. Obviously for women you have much more fibroglandular tissue and less fatty tissue, which is different from person to person. In men, you still can have some breast tissue formation, and that's why men can also get breast cancer. So this is a pretty common statistic, so most people have probably heard this one, but how many of you think that breast cancer is the most frequently diagnosed cancer in women? Yes, it definitely is by a long shot. So there are some warning signs that you can look for just in yourself that might indicate that there's breast cancer forming. The main one is a new lump, something new that you feel that wasn't there before. The normal breast tissue can be very lumpy bumpy. And so part of what it's good for individuals to know is what is a normal lumpy for them. So you might have a cyst or a lump in one area that comes and goes from time to time, but it's the same area all the time. Those are not ones that you want to be too concerned about. The ones that should catch your attention are things that are in a new spot where you've never felt a lump, or a lump that feels different from the lumpiness of the rest of the breast. You can also feel lumps under the arm. Those could be masses, or it could be an enlarged lymph node, and that can be a sign worth getting checked out. Anything that causes a change in the appearance of one breast relative to the other. So if one breast is suddenly a lot larger or a lot smaller, or there's skin dimpling or nipple changes, all of those things can be indicative of something that's actually going on within the breast that you're noticing as an outward change. Now, for types of breast cancer, not all breast cancers are the same. There are a few different types. The main categories are ductal cancers and lobular cancers. And if you think about that anatomy thing that we went over at the beginning, that depends on where in the breast those tumor cells are arising from. So if they arise from within the ducts, then it's a ductal cancer, which is the most common type of cancer that we see. But you can also get cancers that arise from the lobules, and that's a lobular cancer. And then even within those, there are subtypes that have different tumor markers. So breast cancer is not all the same from person to person. It's not treated the same from person to person. And that's part of kind of the purpose of doing things like biopsies, is to get all that information so that your treatment team can decide how that is going to be managed moving forward. This is one that is kind of more applicable to some of this group. How many of you think that breast cancer can occur in young women? It absolutely can. The youngest I've seen is actually a 19-year-old with breast cancer. Obviously, that's incredibly young, but even just in our regular practice, it's not unusual for us to see people that are in their 30s developing breast cancer. So while it mostly happens in older women, it is possible to develop breast cancer at a young age, which is why breast health and breast awareness is so important for everyone. Now, risk factors. I have this conversation a million times a day in the clinic because everyone wants to know what their risk is. Risk is different from person to person, and independent of whether or not you have any family history, your biggest risk factor for developing breast cancer is being a woman and getting older. So 85% of breast cancers happen in people who do not have a family history of breast cancer. So while people focus a lot on family history and the genetic component, those are actually a really small percentage of the breast cancers that we see. So knowing your family history is important because it gives a clue as to whether or not there could be a genetic component. The genetic components to breast cancers usually put you at a higher risk for developing breast cancer. It can be a significantly higher risk. So that family history is important, but it's not the end-all be-all. The biggest risk factors really are being a woman and getting older. There are also a combination of some other factors that can play into what your individual risk is. Some of those are reproductive factors. For women, we look at how old you were when you started your period, when you went through menopause, when you had children, if you had children at all. If you did you breastfeed, did you not? All of those little individual things aren't going to contribute greatly to your risk. But if you have several of those that put you in the higher risk categories, in addition to maybe some family history or some other component, that could be enough to make you at a higher risk than what we would consider the normal population. And then one of the more rare things is chest radiation. So there are some kinds of tumors that people develop in their teens and 20s that happen mostly in the chest and get treated with large doses of radiation to the chest. And those people are at higher risk for developing breast cancer just because of the radiation exposure to developing breast tissue. Now we're going to go through a few things that you can do to lower your breast cancer risk. A lot of these are the same things that you would do to lower your risk for any other cancer. So especially for older women, as you go through menopause and the hormone levels start changing, because that is one of your biggest risk factors, is getting older, maintaining a healthy body weight and eating a healthy diet. And this is true not just for breast cancer, but for a lot of other cancers. Colon cancer is one of the big things that they always talk to people about, is a healthy diet. So nachos may not be the most representative food of what you should be eating every day, but every now and then some nachos are fine. So being active. Again, this is one of the things that you hear for a lot of different types of cancers. Some exercise goes a long way in help keeping your body doing what it's supposed to be doing and reducing your risk for cancer in general. Limiting alcohol intake. While not drinking alcohol at all, obviously, is the way to kind of bottom that risk out. For women, the recommendation is no more than 1 drink per day, is sort of considered like a safer level for alcohol consumption. And choosing to breastfeed. So alone, breastfeeding or not is not going to be the deciding factor of whether or not you develop breast cancer. But there is research that shows that people that breastfeed do lower their personal risk some, and that's thought to be because of the breast cell turnover. So in order to breastfeed, you're forming new cells. Those cells are shedding in the breast milk, and you may be potentially getting rid of some cells that would have developed into cancers in the future. So that cell turnover is a healthy way to get new cells into that tissue and reduce your personal risk. Last but not least, so talking to your doctor about your personal risk factors. So because we've gone through all these different things that can contribute to your risk, it's really a very personal conversation. And there are things that can be done to either provide improved screening for people that are at a higher risk, or even things that you can do to reduce your personal risk. But a lot of that starts with deciding whether or not you are high risk. So talking to your doctor about what your family history is, what your personal history is. Do you have these factors that put you in that higher risk category? Lets them get you to the right people and make sure that you're getting the right testing up front. Okay, we already talked about this one. How many of you think that you can develop breast cancer even if you have no family history of breast cancer? Good, all right, that means people were paying attention. Yes, 85% of breast cancers happen in people who have no family history of breast cancer. All right, so this ties into talking to your doctor. So genetic counseling is a great tool. It can be really helpful for helping people to decide where they fall in their personal risk. So genetic counselors pull in a lot of information. Your entire family tree, who had cancer, what type, what age, map it all out, look at your personal risk factors, and help to identify people that maybe do have that genetic component. Some of the genes that are linked to increased risk for breast cancer can carry up to an 80% lifetime risk of breast cancer. So those women are at an incredibly high risk of developing breast cancer. But if you know that up front, and there are things that can be done to reduce that risk, that's also important to know. And genetic counselors play a really big role in helping to pick out those people that maybe need genetic testing or could benefit from having some additional workup to figure out where their true risk factors lie. If you are high risk and you have a genetic component especially, there are some preventative measures that can be done. And sometimes we hear about some of these in the news, people that find out they carry a gene and have mastectomies to prevent breast cancer. There was I used to get a lot of questions about it when like Angelina Jolie had her mastectomies and Christina Applegate had her mastectomies. So when people find out that they have these genes, one of the things that they do are these preventative mastectomies. There's also some medications that can be taken to help reduce your risk, and those work by affecting hormone levels and helping to block some of those hormone receptors. All right, so how many of you think that treatment is more successful if you catch it early? Yeah, that's true for pretty much any cancer. The earlier you catch something in general, it's going to be easier to treat it, and it's going to be less of kind of invasion just on your life in general, the earlier you catch it. We talked about this a little bit early on. So there used to be a big push for doing self-breast exams. The advice now has sort of gone more to general breast awareness. So part of that is because there was a lot of confusion among people in general about how they should be doing a breast exam, when they should be doing a breast exam, and the research wasn't really backing up that it was necessarily catching any more cancers. So now the recommendation is more to have a general idea of where your normal lumps and bumps are and if something changes. Most women who catch their own breast cancer or feel a lump themselves catch it doing normal stuff like showering or changing clothes, or they notice in the mirror that something looks different, that type of thing. So general breast awareness is a really good time, or is a really good way to do that. If you are of screening mammogram age and you're getting a mammogram every year, a really good time to do a good baseline exam is after you have your screening mammogram, especially if you find out that it's normal. So if you've had your screening mammogram and it comes back and everything looks good, that's a good time to do an exam because you've just had your test. Everything that showed up on the imaging looked nice and normal, so that's a good time to get a baseline for this is kind of what my normal feels like. All right, how many people think mammograms are safe? We have a mixed audience on that one. So mammograms are safe. We do get some questions from time to time about radiation exposure. The radiation from a mammogram is very low. So most of the radiation that your average person gets is just from existing in the world. So you get ambient radiation just walking around. A mammogram gives you less radiation than a cross-country flight. So if you fly in an airplane across the US, you're getting more radiation than a mammogram. Okay, they really are very low dose, and the amount of radiation you're getting from a mammogram is not enough to affect your risk. Okay, it's not going to cause it's not going to cause any cancers to form. When you hear things about medical radiation, that's really a very small percentage of the population. And these are people that are getting higher dose studies like full body CAT scans on a very regular basis over a short period of time. So they may have maybe some sort of severe medical issue that's going on right now. They get a ton of scans over a really short period of time. That can be a really high dose. But something like a screening mammogram once a year is not really significant. It's not going to do anything to raise your personal risk. The way that a mammogram is done is we take 2 pictures of each breast in different orientations, so that way we're getting everything in 2 views, and that's to help the radiologist not only see all the tissue, but if something is identified that looks abnormal, to help them figure out where it is in the breast. If you take something round and you just take 1 view of it, you might be able to figure out where it is in one part, but that doesn't help you. If you know it's on the inside or the outside, but you may not know is it at the top or the bottom. So those 2 views help with localization. If the technologist can't cover the entire breast with those 2 views, they have special views that they add on to make sure they're including all the tissue. All right, so screening. There's a lot of different screening guidelines out there. And in general, the ones that don't say once a year are set by organizations that don't specialize in breast cancer health. So there are some that say, for certain age groups, twice a year, or after a certain age, you can stop altogether. Like I said, those are usually set by societies that don't directly deal with breast cancer health. Across the board, people that actually deal with breast cancer and deal with breast imaging recommend getting screening mammogram every year starting at age 40, okay? For some of our higher risk patients, people that have genetic components, that type of thing, we do have a few people that get mammograms starting at a slightly younger age. It's really a pretty small percentage of the population, but for your personal risk factors play into that. But in general, age 40 and over, once a year, go in and get your screening. And then other tests. So this is also where your risk comes in. There are some things that we offer for supplemental screening that are useful for some parts of the population. So for some of our younger patients, especially that have really dense breast tissue, we'll sometimes use ultrasound as a supplement to mammogram, just because it's a good way to get a second look at that breast tissue and may be able to find some very small masses that just aren't big enough to really show up in the midst of all that dense tissue on a mammogram. And then for things like breast MRI, those are generally reserved for our higher risk patients. Breast MRI is very sensitive. It picks up all kinds of things. It probably picks up a little bit too much for the normal risk population. So we tend to use it more in people that are at a higher risk for developing cancer, because we don't want to be doing a lot of unnecessary biopsies on people or kind of overdoing screening. Screening needs to be easily reproducible and something that people can get done every year without a big intrusion. So mammogram for everybody, and then these other things more on a case-by-case basis. All right, so at MD Anderson, we have 4 campuses now. So there is obviously the one downtown, and then we also have a facility out at the Woodlands, which is where I mostly work, one in League City and one in West Houston, which is out towards Katy. We do a full range of breast imaging at all of those centers. So no matter where you live, there's one that's not terribly far, and we're always happy to see you. All right, and then there are some other cancer prevention programs that we offer, and Kendra can provide some information if people have any interest in those. I did want to go over just a little bit of some of those numbers we talked about. Let me switch over here. All right, so I pulled some of the latest data that's been published from the National Institutes of Health and some of the census data just to try to get the most up-to-date numbers that we can. In general, most of this is going to be dating back to data that was collected around 2019 to 2020. Overall, in the US, you're looking at new cases per year, a rate of new cases of breast cancer per year of 128 per 100,000. Okay, so 128 per 100,000, which is about 0.13% per year. So as common as breast cancer is, it's still pretty rare for people to develop breast cancer on any given year. Now, one of the numbers you hear the most frequently is lifetime risk, and we focus on lifetime risk because while your risk year to year is important, really what we're looking at for each individual person is, are you as an individual going to develop breast cancer in your life? So for the average person, each individual has about a 12 to 13% lifetime risk of developing breast cancer. Okay, and that's what that number equates out to. Now, the death rate from breast cancer is significantly lower. So our new cases was 128 per 100,000. Death rates under 20 per 100,000. So breast cancer is very highly treatable, especially because we have good screening. And most of the treatments are highly effective. So getting good screening helps a lot with making sure that if you are diagnosed with breast cancer, you get to go on and live your normal full life. So doing screening helps that get caught just as early as we can. Now, just like with some other cancers that we've seen, the rates of breast cancer are actually increasing. So we're seeing more breast cancers each year as we kind of move forward, but the death rates are continuing to fall. So even though we're diagnosing more breast cancers year to year, treatments and screening continues to get better, so fewer people are dying from it as we move forward. Now, those are our kind of overall data. So we want to talk a little bit about just Hispanic women in general. So the Hispanic population data is a pool of a really wide range of people. So, I mean, you've got people that are from Mexico, you have people from all across South America. So there's a lot of genetic diversity among Hispanic women. That term really catches a really broad range. But in general, Hispanic women actually get breast cancer at a less frequent rate than non-Hispanic white women. So Hispanic women have a new case rate of about 100 per 100,000 compared to that overall rate of 128 per 100,000. The death rate is also lower, and that's about 13 per 100,000 compared to about 20 per 100,000. So in general, Hispanic women are about 30% less likely to develop breast cancer than their non-Hispanic white counterparts. But when you look across kind of the general, how many people are getting screened, how frequently are they getting screened, are they going in to get the types of things that will help them to have their breast cancers identified, Hispanic women aren't doing as well as their non-Hispanic counterparts. And a lot of that has to do with access to health care. So when you look across census data, one of the things that stood out to me the most is that among the Hispanic population just at large, in that 18 to 64, which covers the bulk of our screening population age, about 26% of people who reported themselves as Hispanic had no access to health care coverage, versus only 9% of the white population. And then you move plus 65, which is where you're starting to get more into Medicare, that disparity drops quite a bit. But in that kind of working age where you see that 18 to 64, there's a large gap in access to health care. And that can definitely change how frequently people go in to get screening mammograms. Screening mammograms are covered by everybody's insurance, but if you don't have insurance, you have to have a way to pay for it. So I always like to make sure that everywhere you are, there is some sort of a program available for people that don't have insurance. One of the things that breast cancer screening programs have actually done really well in this country is there's a lot of focus on breast cancer screening because we know it's effective, it's cheap, it's easy. So there are programs set up everywhere, whether it's through the county, sometimes they're through nonprofit organizations that partner with a hospital system in your area, but those programs do exist to at least get the first level, which is annual screening mammograms to make sure that things are being caught before people feel them. Okay. Did anyone have any questions about any of that? Right, so some of that is what we talked about, that lifetime risk. So your lifetime risk overall is a cumulative number over the course of your lifetime. So as you get older, that risk does go up. And part of that is the hormone changes that people go through as they go through menopause. Your average person off the street at age 40 versus someone who is 60, that 60-year-old is going to be more likely to develop breast cancer from year to year than that age 40, and that's because of the hormone changes that happen in that time period. So your biggest risk factors for breast cancer development are being a woman and getting older. And unfortunately, there's not much you can do about either of those. So breast cancer in men is actually really rare. So it's somewhere around like 1% or something like that, and maybe even less than that. It's a very low percentage. We do see it. At MD Anderson, we probably see more of it than you would see in kind of the general population, and that's because a lot of our patients also have other things going on that may put them at higher risk for developing cancers. But for men in general, what I talk to our male patients about is a lot of the same stuff we talk to our female patients about. It's breast awareness. So if you notice new lumps, especially a lump that is very hard like a rock, that's very concerning for a mass that's actually formed in the breast. The most common thing that brings a man in to see us is actually gynecomastia, which is breast tissue formation in a male. And it can feel lumpy, it can be tender, it can be painful, so it catches their attention and gets them in the door. And then we talk about breast health and the potential for breast cancer. So it is very rare, but it does happen, and it's just important to be aware that if you notice something new, the easiest way to make sure that it's not anything that you need to be worried about is just to go get it checked out. Okay, so your breast density does. So people with very dense breast tissue do have a slightly higher risk for developing breast cancer than someone has more of a fatty breast. But the overall size of your breast does not. Now, the extremes of size, people that have very, very small breasts and people that have very, very large breasts, the challenge becomes more of doing good screening exams on them. Obviously, if you have very small breasts, screening mammograms can be challenging just because of the way the exam is done and actually being able to get the breast tissue into the mammogram machine. And people with really small breasts also tend to have really dense breast tissue, which means they tend to be more lumpy, and it can be harder for them to feel those lumps and bumps. So it's, there's a couple of factors that play in there. And then on the other end, if you have really large breast tissue or really large breasts, the mammography tech may have to take several pictures to cover everything, and positioning can be a lot harder to reproduce from year to year. And it can be tougher for those people to do really good exams just because they have so much breast tissue to cover. Little things may be harder for them to feel in that breast, but the size doesn't mean you're more or less likely to get breast cancer. It's not true. So it can make screening easier, okay? Come on in. And in people that do develop breast cancer that have really large breasts, it's a really common thing for them to undergo breast reduction at the time of their surgery, but a lot of that is more for cosmetics. So it lets them, have an even appearance after they've been treated for their cancer. They may do a reduction on the other side to make the breast more even, or even just to be more comfortable. Some of the patients that I've seen that are the happiest with their breast surgeries are people that had breast reductions. They're usually very happy about their breast surgeries. So it can be. So we hear different. I've heard that there are plastic surgeons that tell people that implants actually make it easier for you to get a mammogram, which is not true. And it also makes it easier for you to read a mammogram, which is also not true. But it's just different. So if you have an implant, it's behind your breast tissue, but it could be on top of the muscle or behind the muscle. So either way, the technologist who's taking your mammogram pictures has to get that implant out of the way, because the implant in the picture blocks a lot of the breast tissue. So on the experience of getting a mammogram, there are more pictures taken to cover everything, and there are some parts of the breast tissue that are just harder to include. And so people that have dense breast tissue and implants, a lot of times we will supplement their screening with things like ultrasound to make sure that we can cover the entire breast, because we know there may be parts of their breast we're just not seeing well on mammogram. Yes, so breast cancers, one of the things that we look at for treatment of breast cancer are these hormone receptors, estrogen and progesterone receptors, and those tumors respond to those hormones. It's one of the reasons you used to see a lot of data from people going on high-dose hormone replacement therapy developing breast cancers. But a lot of that has changed over the years. People don't go on as high-dose therapy as they used to. But you also see things like pregnancy-associated breast cancers because of the anything that causes big hormone changes. If that person was kind of primed to develop a breast cancer, those big hormone changes can be kind of the tipping point that allows that to start. Normal birth control doesn't change your hormones in the same way. So we're talking more about kind of big hormonal swings. So if you go from having a normal hormone cycle to menopause, that's a big hormone swing, right? And the same thing with like pregnancy-induced breast cancers. That's a big hormonal swing. Your normal birth control is more about regulating hormone change. You don't get those big swings, so it doesn't contribute to your breast cancer risk to take kind of your run-of-the-mill sort of hormone birth controls. So breast pain is probably the most common thing that brings people in to see us, and the vast majority of the time it is 100% normal, okay? Breast pain is usually a good sign. So breast cancers don't tend to hurt unless they're quite large or they're involving other structures like the skin or the muscles. So when you have a lump that's painful, it's much, much more likely that that is something that is benign or normal. Painless lumps, ones that aren't tender, are more likely to be cancerous. You never say always or never. There are definitely people who have had tender or painful breast cancers, but a lot of times those are more the exception than the rule. So breast pain, if it sticks around for a few weeks or you notice it in one specific spot but not really anywhere else on either of the breast, that's certainly worth getting checked out. But breast pain in and of itself is very normal. And so if you have breast pain that comes and goes every month, or you notice breast pain for the first time, but it happens to be in roughly the same spot on both breasts, that's almost certainly going to be something that is normal for you and not anything to panic about. But if you notice something specific that sticks around and doesn't go away after a few weeks, it may be worth getting that checked out. That's where that conversation with your doctor comes into play. So not everyone who has a family history necessarily needs to start screening early, but some people do. So in general, we say starting screening mammograms at age 40 or 10 years before the youngest person in a family who was diagnosed with breast cancer. So if you had a mom or an aunt that had breast cancer at 45, you would start screening at 35. If you have a known genetic mutation, you may start screening early. But for a lot of people, their family history is mom or grandma, and they might have been in their 50s or 60s. You're not necessarily going to start screening early because of that. 10 years before would still be older than age 40, so you just start at age 40. Men have the potential for breast tissue, okay? So you're not necessarily going to have any breast tissue that's detectable for most men, but all it really takes is usually it's medication side effects or some sort of hormone imbalance. So we see it a lot just because we deal with other cancers. So the treatments for other cancers, like things like prostate cancer, one of the common side effects of that is gynecomastia formation. So that's one of the reasons we see so many male patients coming in, is because of side effects from medications for treatments for other things. So the newer hormone replacement therapies, which are much lower dose, still carry with them a small risk of breast cancer. Okay, it is much smaller than it used to be, but it is still there. Okay, for your average risk person, it may not even be enough to kind of tip the scales to make you worry about it. But a lot of kind of the conversation people need to have with whoever their doctor is that's prescribing it is that risk-benefit conversation. So for a lot of people, the benefits of their hormone replacement therapy are so high that that little bit of a potential risk for an increase in breast cancer is worth it. You know, the symptoms they're getting from menopause are significant and life-altering, and that hormone replacement therapy does them far more good than the small risk for an increase in breast cancer. But for some people, if their symptoms are not that dramatic, or they feel like they're able to be controlled in other ways, that little bit of an increase in risk may be too much for them personally. So a lot of it really is kind of a personal risk-benefit analysis. Is this, what am I gaining the most from? There are very few people that are told not to go on hormone replacement therapy at all. And again, those are people who have really specific histories. They've either already had breast cancer themselves or they're at a very high risk for developing breast cancer. They may not be good candidates for hormone replacement therapy. But your average person on the street, you know, it's more of a personal decision about what are they gaining versus risking from taking it. We work with some organizations that do screening, like we have Project Valet, which is one of the organizations that we work with that offers screening mammograms. And in the past, we've partnered with some other, like Interfaith and those sorts of things. I'm not sure if we're still doing all of those, with kind of changes from year to year depending on who they decide to work with and who they're funding. But yeah, we do offer some of that. And we usually have mobile vans. Yeah. There's also a mobile van that is around from time to time and is sometimes with those. So if you see those pop up the rows, yeah. You're just lucky. It's just genetics. I mean, you know, some people have denser tissue, some people have less dense tissue. You know, on the average, younger people tend to have denser tissue. That's that hormone effect. And then as you get older, your breasts get less dense over time. So that by the time most people are, you know, in their 70s, 80s, their breast is almost entirely made up of fatty tissue. That's because that tissue is not getting that hormone influence anymore. The fibroglandular tissue starts atrophying and what's left behind is just the fatty tissue. But I've seen people that start screening at 40 that have completely fatty breasts. And I've seen people in their 70s that have very, very dense breasts. So a lot of it's just genetics. Okay, so there's a few things in that story that I feel like we should address. So one, cysts don't become cancer. Cysts are benign and normal, and almost every woman in this room has probably got cysts. Cysts in and of themselves are a benign, normal thing that almost everyone has. They're just little pockets of fluid that form in those lobules. They will shrink and grow in size just depending on kind of how much fluid is moving in and out at any given point. That's part of the reason that people get hormonal breast pain around their cycles is if they have a lot of cysts, those cysts tend to be getting a little bit more full and they get very tender. Okay, so that's part of it. Now, if you do have breast tissue that has a lot of cysts or you've got other things going on, you know, certainly I've seen people that have so many cysts and things in their breast that trying to find a small mass in the midst of all those cysts can be really difficult. That's why you have radiologists that specialize in breast imaging, because even people that do radiology that don't necessarily specialize in breast imaging can definitely get lost in those studies and trying to pick out the one thing in a breast that's full of cyst that's maybe not a cyst, that's something solid. And that's one of the reasons that we do use ultrasound to help work things up and to try to figure out if something is something that's fluid filled or versus solid. Solid is always going to be more worrisome, and cysts are no big deal. Two, should mention family history. 85% of breast cancers happen in people who don't have a family history of breast cancer. So if there's like one big takeaway point for people, I would say that's it, because it's one of the things that I hear the most when people find out they have cancer is, but I don't have a family history. Right, 85% of people who develop breast cancer don't have a family history. So while it's reassuring to you, you know, to know that no one in your family has developed it, it doesn't really mean much for your personal risk. So screening is important even if you don't have a family history. And biopsies being painful. It's an incredibly personal experience. Some people are going to have painful biopsies, but I'll tell you the vast majority of the biopsies that I've done, people do not complain of pain. They go, oh, that wasn't as bad as I thought it was going to be. So most biopsies will not be painful. If you have to have a biopsy, don't freak out about it. It'll be okay. All right. I didn't bring any up-to-date information. There are certain types of breast cancer. Sorry, I moved away from the microphone. There are certain types of breast cancer that Black women are more likely to develop than their white counterparts. One of those is a special type of ductal cancer that's called a triple negative cancer, meaning it doesn't have any of those tumor markers that we look for on the cancer cells. Those triple negative cancers tend to grow quickly and be very aggressive. And that across the population, the group most likely to develop that specific type of cancer is Black women. So, it's very important to keep an eye out. Like I said, if you notice a new lump or one that you feel is different than something you felt before, especially if it's not painful, triple negative cancers do grow more quickly than a lot of the other types of breast cancer that we see, so it's important to get those checked out quickly. So that's what we would call a recurrence. So the chance for recurrence is going to depend on the tumor type. So certain types of cancer are more likely to have a recurrence than others. And some of that also comes down to the stage that your particular cancer was diagnosed. So the earlier a cancer is diagnosed, the smaller it is, the more likely that the kind of typical surgery, radiation pathway is going to be curative, okay? The larger a tumor is, whether or not it's spread into lymph nodes, all of those things increase the risk that tumor could come back at some point. And not all, just because you get breast cancer once doesn't necessarily mean you can't get breast cancer again. We've definitely seen people that had a breast cancer when they were in their 50s, and then it might be 20 years later and they develop a different breast cancer in the other breast that's not even the same type they had before. So one breast cancer it's not a one and done. Unfortunately, if you get breast cancer, there's still the potential for another one to develop at some point. That's unusual, but it does happen, okay? And I've even seen people show up and be diagnosed with different types of breast cancer at the same time. So just like I said, just because you get one breast cancer doesn't mean you're immune to developing any of the others. It's pretty unusual for people to show up with breast cancers in both breasts at the same time. Though, of course, just because your left breast is developing a breast cancer, that doesn't mean the right one goes, hold up, it's not our turn. We can't develop a breast cancer right now because this one's happening. So it's certainly possible and it does happen, but it's not as common as people showing up with a single site of breast cancer, especially on a screening exam. So most of the things that you can do to decrease your risk are the same things that you do for any other cancer. So it's healthy diet, maintaining a healthy body weight, exercising, the same sort of things, cutting down on alcohol consumption, the same things that reduce your risk of other types of cancers apply to breast cancer. And then we also talked a little bit about risk reduction for people that are at a high risk. So for some people that have a genetic predisposition, there are more aggressive things that they can do to reduce their risk, like medications or even preventative surgeries. But that's a pretty small percentage of the population that those would be a good option for. Yeah. So I don't know the exact percentage to give you for that, but if you get to the point, those would be what we call distant metastasis, so those would be stage 4. So it's spread pretty significantly at that point. So those are not typically the cancers that are caught at screening. Those are usually things that were either people that didn't have any sort of mammogram for several years and maybe had a cancer they didn't notice, or that they did notice and ignored, and then by the time they show up, it has spread. So for breast cancer, it really is more of a function of time. So the earlier you catch something, you're much less likely to have had it spread. Just the way that breast cancer spreads, it's generally a pretty slow growing cancer. So screening is really effective for that.
Be sure to follow us on our social media, like this video, leave a comment, and hit that subscribe button to be notified about our latest content.